The management of gallstone pancreatitis, a comprehensive discussion. Welcome to our podcast series, where we delve deep into surgical topics with clarity and precision. Today, we will be discussing the management of gallstone pancreatitis, a condition that demands a structured and multidisciplinary approach. Let us walk through the essential concepts and current best practices for caring for patients experiencing this condition. Understanding gallstone pancreatitis. Gallstone pancreatitis is an acute inflammation of the pancreas that results from a gallstone obstructing the pancreatic duct. The typical scenario involves a stone migrating from the gallbladder through the cystic duct into the common bile duct, eventually lodging at the ampulla of Fada. Management of this condition is a multi-stage process, focusing on resolving the acute inflammation, addressing the underlying cause, and preventing recurrence. Phases of management. The care of a patient with gallstone pancreatitis can be divided into three main phases: the initial resuscitation and medical management, definitive therapy including cholecystectomy and biliary clearance, and finally, prevention of recurrence. Phase 1. Initial resuscitation and medical management. The primary goal during the first 24 to 72 hours is to support the patient, control the inflammation within the pancreas, and prevent systemic complications. Diagnosis involves assessing the clinical presentation, such as epigastric pain that may radiate to the back, accompanied by nausea and vomiting. Laboratory studies are crucial. Elevations in serum amylase and lipase confirm the diagnosis, with lipase being more specific. Elevated liver enzymes, particularly alanine aminotransferase exceeding 150 units per liter, strongly suggest a gallstone etiology. Imaging begins with transabdominal ultrasound, which is the first-line investigation for confirming gallstones and detecting a dilated common bile duct. Contrast-enhanced computed tomography is reserved for severe cases or when complications such as necrosis or pseudocyst are suspected. Risk stratification is performed using established scoring systems like the Bedside Index for severity in acute pancreatitis or the Atlanta classification. Patients with severe acute pancreatitis are at increased risk for organ failure and mortality, requiring intensive care monitoring. Supportive care centers on aggressive fluid resuscitation, typically with isotonic crystalloids such as Ringer's lactate, to improve pancreatic microcirculation and prevent shock. Goal-directed therapy is essential. Pain management often necessitates the use of opioid medications, and patient-controlled analgesia is frequently employed. Nutritional support is tailored to severity. Patients with mild disease may resume a low-fat oral diet once pain and nausea subside, while those with severe disease benefit from enteral nutrition delivered via nasojejunal or nasogastric tubes to maintain gut integrity and reduce infection risk. Continuous monitoring is vital for early detection of complications, including systemic inflammatory response syndrome and organ failure, whether respiratory, renal, or cardiovascular. Pancreatic necrosis is generally managed conservatively unless infection develops, in which case intervention such as drainage or debridement is needed. Abdominal compartment syndrome is another potential complication that must be vigilantly observed for. Phase 2. Definitive therapy. Cholecystectomy and biliary clearance. This phase addresses the root cause of the condition, the gallstones themselves. For patients with mild gallstone pancreatitis, the standard of care is a laparoscopic cholecystectomy performed during the same hospital admission, ideally within the first 24 to 72 hours once the patient is stabilized and pain is controlled. This timely intervention significantly lowers the chance of recurrence, which can be as high as 25 to 30% if surgery is delayed. In cases of severe gallstone pancreatitis, the timing of surgery is more nuanced. Operations are often deferred until the acute inflammation resolves and the patient is medically optimized, a process that may take several weeks. Surgery during active inflammation is technically challenging and carries higher risk. For patients suspected of having stones in the common bile duct, based on findings such as a dilated duct on ultrasound or elevated bilirubin, further evaluation is warranted. Magnetic resonance cholangiopancreatography offers a non-invasive means of detecting stones. Endoscopic retrograde cholangiopancreatography serves both diagnostic and therapeutic roles. This intervention is strongly indicated in the presence of concurrent acute cholangitis, marked by fever, jaundice, and pain, or when there is persistent obstruction of the common bile duct. Intraoperative cholangiography may be used during surgery to visualize the duct, and if stones are found, options include laparoscopic or open common bile duct exploration. or a postoperative endoscopic retrograde cholangiopancreatography. Phase 3. Prevention of recurrence. The most effective way to prevent recurrent episodes of gallstone pancreatitis is removal of the gallbladder. For patients who are not candidates for surgery due to advanced age or comorbidities, endoscopic sphincterotomy via endoscopic retrograde cholangiopancreatography may be considered, though it is less effective and leaves the patient at risk for other gallstone-related complications. Medical dissolution therapy is rarely used due to its limited efficacy and high rate of recurrence. Special considerations. There are unique scenarios that require special attention. In pregnancy, magnetic resonance cholangiopancreatography is safe for diagnosis, and endoscopic retrograde cholangiopancreatography can be performed with appropriate fetal shielding if urgently needed. Cholecystectomy is typically safest in the second trimester but may be considered at other times if conservative measures fail. Post-procedural pancreatitis following endoscopic retrograde cholangiopancreatography is managed with supportive care as described previously. Summary and closing thoughts. The management of gallstone pancreatitis is a staged, multidisciplinary process involving collaboration among gastroenterologists, surgeons, and intensive care specialists. The key principles include aggressive and timely supportive care, prompt intervention to clear the biliary tree when indicated, and definitive therapy with cholecystectomy to prevent recurrence. Adherence to these principles has dramatically improved outcomes for patients facing this potentially life-threatening condition. Thank you for joining us for this episode. If you found this discussion informative, please like, share, and subscribe. This is the Everything Surgery Podcast, where we dissect the extraordinary.